what things do I realise I should have done differently in terms of incorporating aesthetic medicine in my clinic? I started out as a GP with a special interest in skin cancer, so most of my work was, probably 50% skin cancer, 50% general practice. I was in the fortunate situation of having my clinics were separated, so my skin cancer clinic was separated from my general practice. It's very important when you start off in aesthetics to try and remove those patients from the general practice patients, because most of our aesthetic patients do not want to sit around waiting in a crowded room full of bugs, and they also like to be kept running on time. As you know, with general practitioners, we're not very good at doing that. So it takes a while to sort of find that niche where you can fit those patients into your practice. So obviously as a family medicine GP, we're going to have to find a time that those patients, the sick ones, aren't going to be in the waiting room, and that usually involves trying to work out a 1 or 2 hour session a week that is away from the rest of the general practice, maybe an after hours session 4 to 6 or a Saturday morning, that you can start letting it be known that you offer these services in your practice. And you'll find that a lot of your loyal, trusted general practice patients are actually quite happy to know that you're doing it because they trust you. They've known you for 10 or 15 years, so they want to see someone who they can trust for these treatments, and hopefully not go sneaking off to a backyard clinic or someone who perhaps hasn't got the full knowledge of their medical problems, because it's so important when you're doing aesthetic medicine to have that knowledge of what the patient is in front of you in terms of their medical history and their social history and their mental health and well-being. So I find the most difficult thing is first starting it, building up your that catalogue of patients, I guess, that you can use it on, and then once you build on it, you can gradually get to using it sort of 1 day a week and have a whole day booked up. But I found that difficult in the beginning. But the advantage of having a skin cancer clinic separately was good for me, because most of our skin cancer patients are well, and we could separate the aesthetics from that. What else do I wish I could have done differently? It was very early on in the piece I struggled to find a decent course that was relevant to who I was as a GP and a skin cancer doctor. I think so many of the aesthetic courses out there that companies and other presenters offer were aimed at dermatologists, plastic surgeons, nurse injectors, all of whom really didn't have that same base of patients that I had. So the HealthCert courses were designed specifically for that in mind. So to have general practice being the primary focus was ideal, and fortunately we've now developed a course that's become very popular because it's focused on primary care doctors and skin cancer doctors, because they obviously see a lot of solar damage patients who will age faster. One problem I had starting up was trying to convince my colleagues, who are very staid and conservative in their skin cancer world, that it was okay to have Botox in your practice, and you'll get that when you start up. Often people will say, "Are you fearful of your reputation being ruined?" But I think if you take a step back and say, "No, I'm approaching it from a very scientific, evidence-based approach. I'm doing the appropriate training. I'm incorporating it for my skin cancer patients who all need this sort of advice," your credibility will be maintained. But there is that fear when you first go into it that you'll be seen as someone who's trying to make a quick dollar, when it's not about that at all. It's about creating happy patients and providing a one-stop skin service for your patients all in one place.